have something called the islet of Langerhans. You can see this green box here. And the islet of Langerhans is a cluster of cells. So think of it as something like a pizza. It's got all sorts of ingredients on it. So this islet of Langerhans is the functional part of the endocrine pancreas. And it's made up of your beta cells, alpha cells, delta cells, and F cells, and they each produce different types of hormones. So the beta cells produce your insulin, which is something that we will be discussing afterwards. Alpha cells produce glucagon. It's also important for regulating the sugar. Delta cells, which is your somatostatin, and F cells, which is your pancreatic polypeptide. We'll be covering these two hormones, your somatostatin and pancreatic polypeptide today, but we will be covering insulin in depth afterwards. The adrenal gland, which will be covered in another lecture on a different day, okay, is divided into your cortex as well as the medulla. So the medulla makes up the core of your adrenal gland, and your cortex makes up the shell or the outer layer surrounding the core. Now each layer produces its own different hormone. Your medulla is responsible for producing the catecholamines. Cortex is responsible for producing the aldosterone, cortisol, and estrogen, and testosterone. And the cortex is divided into three layers: your zona glomerulosa, zona fasciculata, and zona reticularis. Every single layer produces its own hormone, and we will be talking in depth about that on, I think, the third or the second lecture of this series. The thyroid gland, very important, located at the neck of our canine and feline patients. It normally produces three different stuff, which is your T4 tyrosine, T3 triiodothyronine, as well as your calcitonin. T4 gets converted into its active form T3 by 5-deiodinase, and calcitonin works opposite to a parathyroid hormone to reduce calcium levels in the blood, whereas your parathyroid hormone, which sits on your thyroid gland, is supposed to push calcium levels up within the patient's blood. Now, the endocrine system is important because using these hormones, organs are able to communicate with one another. So from the brain down to the thyroid gland, etc., and they communicate back to the brain as well. Now, I was hoping that it will be this simple, but unfortunately it is not. It's more like this, where everything, all the organs are talking at the same time. All the organs they want to communicate at the same time. They all want attention, and everything is in sort of like a buzzing, haywire maze of communication. It's total chaos. So what happens is that our body has to control what's happening. It has to have some measure of coordination, and most of this is actually done by the hypothalamus that's located at the base of the brain over here. Okay, and how this happens is that there is a form of effect known as the negative feedback response, which I'll talk a little bit about afterwards. But bear in mind that hypothalamus in our brain plays a very important role to coordinate and exert its effect upon the endocrine and nervous system of the body. So this is a simplified version of a negative feedback loop where endocrine gland A produces hormone A, okay, and hormone A then exerts its effect on the target organ, alright, and hormone A, once it hits a certain level, a certain concentration, it then gives off a negative feedback loop to the original endocrine gland and asks the endocrine or signals the endocrine gland to stop producing hormone A. But it's normally not that straightforward, and it's actually a bit more complicated than that. So generally there's something called a hormone cascade, meaning that the hormone that's produced by the original or by the primary endocrine gland, we have to go through more than one particular endocrine gland to exert its effect, like in this particular case. So here we have got endocrine gland A, which produces hormone A, and hormone A then activates endocrine gland B, which then produces hormone B. And hormone B then only has its effect on the target organ or the body. It's negative feedback loop from the effects of hormone B, okay, will then send a message back to endocrine gland A, asking endocrine gland A to stop producing hormone A. So this is a bit more complicated. It's a hormone cascade. You have to go through more than one layer of endocrine gland to get its effect, to get its what do you call, to get its desired outcome. So what we'll be covering in this lecture will be the pancreas, diabetes mellitus, thyroid gland, hypothyroidism and hyperthyroidism, the adrenal glands, hypoadrenocorticism and hypoadrenocorticism. So without further ado, let's talk about diabetes mellitus tonight. So first off, I want you to understand that diabetes mellitus happens due to a condition where the body lacks insulin or the body is resistant to the insulin that is being produced. Diabetes mellitus can be divided into type 1 and type 2. Type 1 refers to no insulin or insulin dependent, meaning that the patient bears with Goldilocks cannot produce insulin, so which means that their body requires an external source of insulin to help them with glucose metabolism. So that's type 1. Type 1, the body can't produce insulin and we have to give an external supply of insulin to the patient. In DM type 2 refers to inadequate insulin, delayed insulin response, or maybe even there is normal amounts of insulin, but the body is resistant to insulin. So it means that the body has the insulin, but the cells cannot respond to the insulin. Now, always remember that the hallmark of diabetes mellitus is hyperglycemia and glucosuria. We'll talk about that a little bit more. So, endocrine pancreas, okay, is very important because it actually has the islet of Langerhans that contains our beta cells. And these beta cells of ours, okay, produces insulin. Now, insulin is normally secreted in response to higher blood glucose, so which means that when the beta cells pick up that there's an increase in blood glucose concentration, it will be signaled to actually produce insulin. And why this is important? Because insulin is responsible for the absorption of glucose by the cells for its metabolism. Remember that if there is no insulin, okay, the cells cannot utilize glucose for metabolism. Now, if you look at this diagram down here, all right, where I've circled the diagram islet of Langerhans. So you have to bear in mind that this again is a feedback loop where when the beta cells sense that there's an increase in blood sugar, they release the insulin. But when they sense that the blood sugar levels have dropped, they will actually decrease the insulin that is being produced by the beta cells. Okay, so this itself is a form of a feedback, negative feedback. Now, how does it look? So here in the corner here, you see this round sphere. This represents insulin, and this yellow peg or this yellow rectangle represents an insulin receptor. What happened over here is the glucose channel which is closed. So what happens is that the insulin will have to attach itself onto the glucose channel, which will then lead to the glucose channel opening and allowing the glucose glucose to enter the cell for metabolism. Now you have to imagine that insulin acts as a key, alright? The insulin receptor is the lock. So when the insulin attaches itself to the lock, it will then unlock the glucose channel, alright, which acts as a door to allow the glucose to enter the cell. So let's say if there is a problem with any part of the steps here, whether you don't have enough insulin, or you have no insulin, or your insulin receptors are damaged, or having issue, or there's a problem with it, or if your glucose channels don't work, then glucose is not able to enter the cell and do its job. Now, bear in mind again, I have to remind you that when there is no insulin, hyperglycemia occurs, which is excessive sugar in the blood. Now, why this happens is because the body now cannot utilize the sugar in the body. So when you consume food, when the patient consumes food, all that sugar is going to stay within the blood. So hyperglycemia, meaning excessive sugar in the blood. At the same time, because now sugar cannot be utilized because you don't have enough insulin, protein and fat will be broken down. So if you see this picture down here, this poor little fella, cachexia is where the patient is wasting away. So you lose muscle mass, you lose fat, because the body is now breaking down all the muscle and fat as it cannot utilize sugar, because it cannot utilize insulin, or there's not enough insulin within the body. Right. Now back to hyperglycemia. So what happens is that we learn in physiology that sugar is filtered in the kidney, alright, and within the renal tubules, the sugar is then reabsorbed back again into circulation. The problem with hyperglycemia is that when you have this excessive amount of sugar in circulation, all of this sugar is going to be filtered out via the kidney, and because the renal threshold has been breached, meaning that there's just so much sugar that the kidney is not able to reabsorb everything. So which means that a significant amount of that glucose or the sugar is going to have to be flushed out in the urine. And this condition is called glucosuria, means sugar in urine. Okay, so imagine that now the sugar is very sweet. There's a lot of sugar. The urine is now very sweet. There's a lot of sugar in the urine now, and then this will increase the osmolarity of the urine, leading to something called osmotic diuresis. Now, when osmolarity goes up, we all learn in chemistry, it's going to pour water towards it. So this high osmolarity urine, this glucosuria, is going to retain water within the renal tubes. It's going to try to attract more water in. Okay, it's going to pull electrolytes in, leading to a condition called polyuria polydipsia, meaning you pee a lot, you drink a lot, as well as dehydration. Because you pee, you're always urinating because of the osmotic diuresis, it's just pulling all the water out and leading to the patient being very dry because you're just moving all that water. Okay, and you'll be constantly thirsty. So the patient will be constantly thirsty because he's dehydrated and he's constantly peeing a lot. So let's just say if you're ever in case and you get a dog or a cat coming in over telling you that my cat drinks a lot, he pees a lot. It's not just kidney failure, you always have to think about diabetes mellitus is one of the differentials for a cat or dog that pees a lot and drinks a lot. So again, just let you all know, cachexia means loss of muscle mass and weight, so the body wastes away. Polyuria means frequent urination, and polydipsia means frequent drinking. Now, hyperglycemia due to diabetes mellitus, this happens because there is, like I said earlier, there's too much glucose being filtered out. It overwhelms the kidney's ability to reabsorb it back into circulation. So the kidney is overwhelmed. The kidney is just not able to reabsorb back all of that sugar, and a lot of that sugar that escapes via the urine Now, this increases the osmolarity of the renal filtrate, leading to more water being pumped to renal tubules, osmotic diuresis, leading to pulmonary polypsia and dehydration. So, what are the clinical signs? So, as a clinician, if you ever go into practice one day, patients of mine come in, if the owner mentions um, there has been a gradual weight loss, muscles are wasting away, that's cachexia. Some of them will come in with recurrent UTI. UTI means urinary tract infection. Okay. Polyuria polydipsia. Okay, due to the osmotic diuresis. And these guys will be really hungry. Sometimes, all the time, if they're really sick, if they're already DKA, then they of course wouldn't be hungry. But in many of those cases, many of my patients when they come in, they will be polyphagic. They will be really hungry. They want to eat. They'll be eating stuff off the table. They will be begging for food all the time. From a dog that was maybe very picky, the owner may give you some history and say, oh, that no, my dog is not really hungry all the time. Don't know why. He's eating, but he's losing weight. He's drinking a lot of water. He's peeing a lot. He's really upsetting me at night. At night he has to wake me up to take him out to make pee. This never happened before. So one of the differentials that we always think about, other than your renal failure and your hypothyroidism, you really have to remember that diabetes mellitus looks just like this as well. Okay, so in your head you have these differentials where you think, okay, I got DM, I got hypothyroid, I got chronic renal failure as my differentials, which would potentially cause all of these clinical signs that you see above. Okay, so bear in mind that if you see these clinical signs, diabetes mellitus should be on your list of differentials. Okay, so how do we diagnose DM? What is it diagnosed based on? So there are some common things which you always have to remember. These guys, the hallmark of the disease again is persistent glucosuria and persistent hyperglycemia. That's one thing. Characteristic clinical signs that you will get from these patients will be their PUPD. They are polyphagic. If you catch it early enough, they're not pretty hungry. Muscle wasting because the body now cannot make use of sugar. So they're breaking down protein, breaking down fat. So these guys are losing weight because they eat a lot, which is a paradox. Other clinical signs, concurrent infections are common. I often get patients coming in with a urinary tract infection, pyoderma or a respiratory tract infection. Now, why I highlighted urinary tract infection is because these patients, you have to imagine, they have got glucosuria, so they've got a lot of sugar in the pee, in the urine, in the bladder. Glucosuria is a wonderful media for bacteria because of sugar. Bacteria can utilize the sugar for metabolism, so it becomes a wonderful media, and that's why these patients come in with a UTI problem, or maybe it's a patient with common UTI, and they say they've already been treated for. After a month, it keeps coming back again, and you ask yourself, okay, why are you coming back with a UTI problem? Is there something wrong in your pee? That's why it's a wonderful media for bacteria. So if you're having this kind of conditions where you got recurrent UTI, recurrent infections, and to think about whether you may be having a DM issue or not. Now, peripheral neuropathy is common in cats. Okay, and then this causes what we call a blunt degrade stance. You see the arrow here. So basically, they don't stand and walk like a normal cat anymore. And this happens mainly in more chronic cases of diabetes mellitus. And you'd be surprised where a lot of clients don't even realize that cats have DM, and they come in, they say, oh, my cat's been having this PUPD, drinking a lot of pee for like 6 months already. I'm wondering because he was losing the weight, or he's walking funny, he can't jump on furniture anymore, he can't jump on the bed anymore, he's limping. So actually when the cat in for maybe a different problem, like a limping issue or a mobility issue, then if you look at them and you see them having this plantigrade stars, and in some severe cases, they even have palmigrade stars. Palmigrade would be where the fronds are actually affected. So if you see these plantigrade stars, so you really just shouldn't think about neural tissue. You should be thinking, is my cat having TM? It's one of those classic chronic TM cases. Cataracts are frequently seen in dogs, but it's not really a cat issue. I have seen some cats with cataracts, those TM cats, but not very common. More rare, more rare. So, why do dogs develop cataracts if they actually have diabetes mellitus? This happens because within the lens of the canine patient, an enzyme called aldose reductase reduces sugar alcohols and is not forming and accumulating sorbitol and galactocol in the lens. Now, most of these compounds are actually hydrophilic, which means that they love water. So they actually pull water into the lens. Okay, they increase the osmolarity of the lens and start pulling water into the lens. And this sudden influx of water to the lens expands the lens. It damages the lens fibers, causes inflammation within the lens, and subsequently cataracts will then develop. Now, regarding feline diabetic neuropathy, it is very rare in canine patients. I have not really seen one before, okay, but I do see it very commonly in my feline patients. It is a very important chronic complication in cats because it affects their mobility. Most cats, like my own cat, for instance, can jump, run, actually likes to climb up my cabinets. So this especially affects their quality of life. From a cat that used to be so hyper and so jumpy, now it can't jump. When it tries to jump, it may get hurt because it can't jump high enough. Stuff like that. So you really have to bear in mind that when you are discussing these things with the client, based on the history, they'll be telling you about the mobility being reduced. Maybe they will tell you that my cat is now more hesitant and trying to jump. Is it because it was having high leg issues? Then you have to ask more history in regards to its appetite, to its water intake, to its toilet habits. And if you know these little pieces of the jigsaw puzzle fit together, it's got PPS, maybe using more water recently, etc. Then maybe you go to a blood draw and then check whether this cat's got diabetes mellitus or not. Okay, now I highlighted the square around this, so just let you understand that this feline diabetic neuropathy tends to occur due to nerve damage in the hind limbs. Now over here is a cross section of nerve axon. Okay, so here the blue arrows here, right, shows where this is the endothelial blood vessel. And these blood vessels or these capillaries supply oxygen and nutrition, etc. to the nerve axon. So if you look at A over here, it's very nice, it looks normal. The structure of the capillary looks nice, you don't see any more about it. But on B, you can see that it's standard. You can also see that it's actually a bit more thickened in terms of wall. Okay, there is significant structural change compared to the normal blood vessel A. So when this happens, alright, you're going to have, of course, less oxygen, less nutrition, etc. being carried over to the axon. Now, this endothelial microvascular pathology is pretty common in diabetic cats, unfortunately. There is, of course, going to be demyelination of the axon because of this, and degeneration of nerve fibers. So basically, the diabetes mellitus is starving the nerve of nutrition, of oxygen, and it's also, I guess, preventing waste material from being removed as well. Because so things can't get in, so things can't get out as well. And this causes nerve degeneration and leading to that plantigrade stance, which we can see over here. So other chronic complications of diabetes mellitus, other than cataracts, would be, and your diabetic neuropathy would be diabetic nephropathy. as well as systemic hypertension. Our lecture today won't be covering these because it can be quite extensive, but bear in mind that these patients may develop other secondary problems as well due to the primary diabetes mellitus which they're having. So let's talk about diabetes mellitus type 1. So it is basically a canine disease. Okay, so dogs generally get type 1 insulin dependent diabetes mellitus. It's normally a congenital disease and normally occurs due to beta cell aplasia of degeneration. What happens is that there's an autoimmune destruction of the pancreatic islets, especially of the beta cells. Sometimes, in certain breeds that are notorious for pancreatitis, they may develop chronic pancreatitis, which then leads to digestion of the pancreatic cells, especially the beta cells. And due to the chronic pancreatitis, the beta cells are destroyed and cannot be replaced after that. Other conditions such as cancers, very stress due to growth hormones, cortisol, so hypercorticism can lead to antagonism of insulin, which means that these dogs may have another primary disease, leading to the body not being able to respond to insulin. So basically, you can imagine in canine DM type 1, the pancreas is destroyed by an immune mediated mechanism, something which we're not quite sure why. That's why they believe that it is a genetic condition where the pancreatic cells have certain receptors are being marked out to be destroyed by the immune system. Okay, the cause is still unknown. So some common breeds that we have to be aware of: Dachshunds, Beagles, Bichon Frise, Schnauzers, Keeshon Pugs, Cane Terriers, Silkies, Poodles. Generally, I see quite a fair bit of Schnauzers in my practice, and Poodles come in with diabetes mellitus. I think also because it's a pretty popular breeds where I practice, and a lot of them come in and they have TN type 1, and they have to be given insulin as a form of treatment. Now, bear in mind, and something for you to remember, in diabetes mellitus type 1, there is no insulin production by the pancreas. So generally, these patients will require insulin lifelong as a form of treatment. Now, let's talk about DM type 2 diabetes mellitus type 2. Now, it is basically a cat disease. Um, most of the cat diabetes mellitus will be a diabetes mellitus type 2. Now, what happens is that in these patients, there is a lack of reduced insulin production, and in some cases, due to insulin resistance developing. There are some predisposing factors, such as if you're a male cat, you're a cat with a very chill lifestyle, sedentary lifestyle, inactivity. If you're an obese cat, just like human beings as well, if the cat has been on prolonged corticosteroid therapy, pancreatitis, because the disease will damage and destroy some of, if not all, of the beta cells, and hormonal antagonism such as Cushing's disease. So before we dive into DM type 2, let's just do a quick refresher about how this works. So insulin acts as the key. It has to attach itself to the insulin receptor and trigger the glucose channel to open before the glucose can enter into the cell. Okay? So in DM type 2, the pathophysiology of how it can occur, there are three mechanisms. Number one is either you have reduced insulin production, that means even some insulin, but not enough for the body to use. And due to that, the body is able to utilize the glucose effectively and efficiently. That's the first one. The second one, okay, occurs due to an inactivation of insulin receptors, which means that Something else, maybe inflammatory mediators or maybe another antagonistic hormone may have attached itself onto the insulin receptors. So maybe these cats have not enough insulin, but because the insulin receptors been attacked or have something attached to it, some other kind of enzyme or hormone or inflammatory mediators, and because of this attachment, they inactivate the insulin receptor, and because of that, the insulin cannot attach itself. The third thing would be inactivation of the glucose channel. So which means that okay, fine, insulin receptors are working fine. There's nothing messing with it. You have enough insulin. But the problem now is that after the insulin has attached itself to the insulin receptor, the door won't open. Or maybe there's something jamming the door out. There's some inflammatory mediator, or maybe there is some form of bacteria or virus that has attached itself onto the um, glucose channel, and that is preventing the glucose channel from opening up and from functioning, and doesn't allow glucose to enter into the cell. So there are basically three ways which DM type 2 cats may occur. So the first one, just a recap, reduce insulin production. Okay, so there are not enough keys for all the locks. Lock, okay, inactivation of the insulin receptor. Maybe someone has put chewing gum into the lock, so now the key can't go in. Or maybe the key and the lock is working, but now the door is jammed shut. The door just can't open. Even though the lock is working and even though the insulin, so even though there are enough keys for it. Now, a quick recap here, or rather a quick look at this table. Now, cats aren't dogs and dogs aren't cats, and the disease manifestation is also different. Now, this disease often involves the deposition of amyloid in the islet of Langerhans for cats. Whereas in dogs, we're talking about total islet of Langerhans destruction in most cases, or all of them. So in cats, you may have a certain percentage of your islet of Langerhans or beta cells with amyloid, and a certain percentage with no amyloid. So those that are not affected with no amyloid can still produce some insulin. Whereas in dogs, we're looking at all of the islet of Langerhans destroyed by the autoimmune system. Cats are more likely to still have some pancreatic function at diagnosis, and I'm like, okay, so their sugar levels may wax and wane, so meaning that in some cases, these cats may actually go into remission. They may actually require insulin for maybe a few months, few weeks, and suddenly after a few weeks, their sugar levels are normalized. They do not require insulin or they don't require treatment anymore. And that's because of maybe of the treatment that we have actually put in place. Whereas in dogs, remission is unheard of, and this is because they have lost their pancreatic function to produce insulin. Diabetic cats are more likely to be obese, whereas in dogs they are less likely. In fact, they are more likely to be very skinny because a lot of them are cacaxic by the time they come in. Oral hypoglycemic agents might be beneficial in some diabetic cats, but not all of them. So in some cases, if you still have got a significant amount of beta cells still working, then all anti-diabetes drugs may actually still work for them. Those are available. Whereas in dogs, because they do not have any more beta cells, their pancreatic cells are already damaged. Oral anti-diabetes like drugs generally don't work for them. I personally don't see what I've received cases coming at my doorstep when the dog was on oral anti-diabetes drugs for weeks and they just deteriorated and they developed diabetic ketoacidosis after that. Bear in mind that in management, cats may be hard to control their diets because cats are grazers. Okay, and some cats being just purely lazy, they may not want to exercise, they may not want to play. And we've had that quite a fair bit with some of my patients. Whereas in dogs, they tend to want to play more, and they're not really grazers, so their diet and appetite, so their diet control seems to be better. So diagnosing that. So let's just say now we have done your history, you know the demographics about these patients with diabetes mellitus. Okay, so now you suspect, okay, no TM is one of my differentials. I need to confirm whether this patient is having diabetes mellitus or not. So what we do, okay, after physical examination, we draw blood, we run CBC, we run serum biochemistry. Generally, in these patients, they will have an increase in ALP, alkaline phosphatase. They will also have an increase in liver enzymes because the liver is stressed out because of oxidative stress because it's working very hard as the body cannot utilize sugar. So it's working very hard to break down protein, break down fat, to try and provide food for the patient. A lot of these patients also have hypocholesterolemia and lipemia as well. Okay, but most importantly, these fellas will most likely be hyperglycemic. Now, bear in mind that you're dealing with a very hyper-excitable patient, a very hyper-excitable chihuahua, or you're dealing with a cat that's really stressed out. The hyperglycemia that you get from the blood report may be a false positive. Okay, because you have to understand that when they come into the clinic, the white coat effect stress may cause an increase in blood glucose level. Alright, so if that happens, you got to okay, so his history fits the bill. He's hyperglycemic. I'm still not 100% sure, so what do we do? So the next test that we can always do, and which I encourage you to try and get done, is something called fructosamine. And fructosamine for the time being is point of care GP practice. It is still the gold standard for diabetes mellitus testing. Now, fructosamine is able to confirm for us the limited presence of hyperglycemia. So if you just test or just rely on the hyperglycemia or the high glucose level on your blood biochem test, it's high glucose you're looking at it. You're concerned that maybe the hyperglycemia is due to a spike in the blood due to stress. So you're wondering, okay, what about long-term hyperglycemia? Was it hyperglycemia in the last 2 weeks? Was it hyperglycemia in the last 3 weeks? So fructosamine is able to show us the average glucose concentration over the previous 2 to 3 weeks. Okay, so what it means is that if we run for fructosamine and if we were to see fructosamine is high, it means that this particular patient already had high fructosamine 2 to 3 weeks ago, and which also means high glucose. Okay, so what is fructosamine? It's basically plasma proteins, meaning albumin, that have undergone non-enzymatic, irreversible glycosylation in proportion to the surrounding glucose concentration. So which means that if you have high glucose, you're going to have high fructosamine at the same time. So this is the gold standard for diabetes mellitus diagnosis, because we can tell that fructosamine, if the fructosamine is high, that means that this cat or this dog was already hyperglycemic for at least the last 2 to 3 weeks. Okay, now it is available at point of care testing, which means that there are machines out there which a clinic or a hospital can buy and can put it in your practice. It can be tested within 20 minutes, 30 minutes, and can have the results very fast. Okay, it can be used to rule out stress hyperglycemia. Okay, so by running a fructosamine test, we will avoid false positives for hyperglycemia. Okay, now some of you may know this HbA1c. So what about HbA1c? So HbA1c is basically glycosylated hemoglobin. It's where glucose glycosylates with hemoglobin protein within the red blood cell. So if you have high blood glucose levels, you will have high HbA1c as well. Um, it's good if you're looking back at a longer period of time, like 2 to 3 months, because HbA1c will actually show you the average blood glucose levels way further back compared to fructosamine. It's not commonly done in point of care setting, it's in GP clinic or even in hospitals, because there are not many machines out there that can do this for us yet. The only machine I know in Malaysia that can run HbA1c will be the Antiscan machine from Korea. And it's not a machine that many of us has. I mean, we have got one. Um, we really use it because it's really expensive. I think one time to run HbA1c costs like 200 ringgit. As fructosamine may only cost about $80 only. So it's not something that we run very often. Um, okay, but it's something that I think will become cheaper over time, and that's something that you may see in the near future. Okay, so how do we diagnose diabetes mellitus? The clinical signs: PUPD, dehydration, and elevated blood fructosamine levels. Remember, this is actually gold standard. Okay, now diabetes mellitus therapy. So we're going to treatment next. Um, Dogs are not similar to cats. You have to bear in mind that cats, they may wax and wane. Some cats may go into remission post-treatment, so which means after we treat, after 2 months, 3 months, diabetes may just disappear. This happens because maybe whatever underlying problem that was causing the diabetes in the first place may have gone away. Maybe the pancreatitis got treated for and the cat got better from it. Whereas cats do not generally wax and wane, and this is because dogs, when they get type 1, they've basically lost all of their beta cell function. There's going to be this massive destruction of their beta cells. And these dogs do not recover from it because the beta cells do not grow back, they don't recover back after the destruction by the immune system. So what's the cornerstone therapy for dogs? So remember three things, which is that insulin is the only effective therapy for dogs. Okay, I don't even bother trying to go for oral anti-diabetes drugs for my dog patients. Immediately we diagnose a patient with insulin, we tell the client upfront, look, you're going to have to excite to jab your dog every day with insulin because oral diabetes drugs just don't work. And if the owner tries to argue with you regarding that, and later we're going to talk a little bit about the oral drugs, you have to explain to them why it doesn't work, the pathophysiology of the disease, as well as the mechanism of the oral anti-diabetic drugs. Okay, which we shall talk to you a little bit on afterwards. Dietary management is important. I mean, we know many of us have family members with diabetes, quite a number. Because in Malaysia, diabetes mellitus is one of the top non-communicable diseases, and you understand that for your family members with diabetes, you want to jaga makan. Okay, so now Penang having durian season, so unfortunately people with diabetes mellitus have to jaga lah, so cannot take durian, cannot take sweet stuff. So same for dogs as well, you have to watch their diet, you have to go on specialized diabetes diets that's high in protein, carb, if the carbs like complex carbohydrates, etc. And just like humans as well, exercise is important because you want to exercise, you want to get the muscles moving, you want to encourage weight loss, etc. So the cornerstone therapy for dogs is the insulin, dietary management, and exercise. Now for cats, almost the same. It's just that now for cats, you may consider oral hypoglycemic drugs. You may consider oral anti-diabetes mellitus drugs. Most of my patients actually go on insulin. The reason why is because they may initially work with the diabetes drugs initially, like maybe for a few months, but somehow many of them after a while, the beta cells die out, or the amount of insulin that can be manufactured or produced by the beta cells just aren't enough because the oral hypoglycemic drugs maybe would have caused an over exhaustion of your beta cells. You see, so now you need insulin. So I would say the majority of my patients, and even my own cat, I've got one cat with diabetes, they're all on insulin at the moment. Dietary management is very important. Just like human beings I mentioned earlier, you have to watch what kind of food they're eating. They cannot be taking food with high carb, especially simple sugar. It's going to make the sugar go haywire. And exercise, losing that weight, make the body burn, make the body utilize all of the energy, all of that sugar. There's no point if you inject them with insulin, but you don't get them moving because then you're not going to encourage the cells to actually pull in all of that sugar from circulation. So even just like human beings, for especially diabetics, after they give the insulin, they still have to go for a nice walk. Once you want to encourage this movement, then you have to actually encourage the cells to make use of that sugar, to pull in all of that sugar into the body, to break down and to be metabolized. Okay, so just a note, rapid weight loss is one of the best things we can do for our patients. Whenever we talk to our clients, whenever we manage them, whenever we advise the clients, if they know that an overweight patient is more likely to be insulin resistant, or we may have to use more insulin. Okay, whereas if you're able to reduce the weight of that patient, okay, insulin resistance actually drops, insulin actually works better. When you actually use less insulin, you will be surprised that research has shown that overweight cats that lose weight in the first month of treatment are 15 times more likely to enter remission. And you ask, why does this happen? And it's most likely because a lot of these cats, they are DM type 2, so which means that they still have some pancreatic function left. So when you're a chubby 9 or 8 kilo cat, what happens is that now your pancreas needs to produce insulin for 8 kg worth of cells. And if you check the cat, you realize that I think the patients are with maybe 6 kilos or maybe 5 kilos. So let's say if you put the cat through exercise, through dietary control, you are careful that the cat doesn't go into fatty liver disease because you're controlling his diet and etc. You will notice that as the cat loses weight, the likelihood of remission goes up because now the pancreas doesn't have to produce insulin for 8 kg worth of cells. He only has to produce insulin for 6 kg worth of cells, 5 kg worth of cells, 4 kg worth of cells. So which means that now the amount of insulin required by the patient reduces because the amount of fat that is utilizing up this insulin is no longer there. It's gone away, and that the body has actually lost. So the body is now a lot lighter, and its insulin requirement also drops. So that's another reason why one of them actually go into remission after they've actually lost weight. So that actually is something to think about. So what are the aims of therapy for toxic cats? To achieve normal glucose readings long term can be challenging, sometimes impossible. But that won't be the whole way of thinking. We'll talk about what some newer train of thought is now coming out. But the whole dogma was to reduce clinical size, means you want to reduce PUPD, you want to reduce the polyphagia, you want to reduce the scavenging of food from the table, from the dustbin, etc. You want to improve quality of life. Now, when I talk about quality of life, I don't just mean for the dog or for the cat, I also mean for the human being as well. So imagine if you have a dog with diabetes mellitus, and imagine if his sugar isn't controlled. It's not on insulin or you have a cat Now these guys maybe will be very, very hungry. They will always be, rummaging through rubbish bins. They may jump on the table trying to steal food from the owner, okay, off the dining table. Imagine you are an owner with a dog that sleeps with you, and imagine if your dog is having PUPD, and if you are not aware of it and you just sleep through the whole night, your dog needs to go and pee. Your dog could actually be peeing on your bed, peeing in your room, peeing in the house, and that's also not so good quality of life for the owner as well. Imagine the dog has to wake up in the middle of the night to go and pee. That isn't quality of life. Imagine if you're always needing to go and drink. Imagine if you're always thirsty, you're always hungry. That isn't quality of life. You always imagine if you're that dog, you're that cat, you always want to be thirsty, you always want to be hungry. No, that's not something that you want for them. So you want to improve the quality of life, you want to improve the clinical signs, you want to improve and maintain good appetite and body weight, normal appetite especially. And you want to minimize the development of complications associated with the disease and with treatment. Okay, so this is generally the aims of therapy that was taught a long, long time ago, still being taught today with more advance at the moment. So, how do we maintain this disease? What do we look at long term? Insulin, and I mentioned, and they are divided into short, intermediate, long acting forms. Diet, you want to choose a diet that is high in protein, high in fiber, makes them feel full. Okay, have to be high fiber, complex carbohydrates, because they take longer to actually break down, so you have less instances of sugar spikes. Weight loss in obese animals, so if you are a fat chubby cat, you want to try to cut down the cat's weight, make it healthier. And you may want to consider oral medications, type A cats, okay? But please bear in mind that oral hypoglycemics will not work for dogs. Now, a proper diet prescribed. Now, the two main brands in Malaysia, okay, will be your Royal Canin Diabetic for cats. We also can use Royal Canin Satiety as well for cats, for dogs, of course. Um, it's high fiber, good quality of protein, and low in simple carbohydrates. So you want these guys to have complex carbs and not simple carbs, because simple carbs tend to break down very fast. They break down fast and they start to have spikes in sugar, spikes in glucose, and that makes it very difficult to manage them. Okay, no treats, no fruits, no nothing. A lot of my clients love to give their dogs blueberries, apples, etc. They contain sugar, so fruits contain unnecessary sugar that's going to mess with their diabetes management. So no fruits. Even treats as well will have sugars, will have unnecessary calories, make them put on weight, so you can't get them under control. They have unnecessary simple carbs. That's why some dogs may love their treats because it's really sweet. Okay, makes them not want to eat all the time. So that becomes a problem because you generally can't give insulin on an empty stomach. If not, you're gonna go into hypoglycemia. So you want your patients to eat on time. Okay, and you don't want these unstable glucose levels, these sugar spikes. There's not around due to the unnecessary food that's been fed. Always bear in mind that it's not just the treatment that as a clinician you have to look at. It's very important that you emphasize to the client you have to monitor the patient at the same time for two reasons. You want to avoid hypoglycemia, which is very, very dangerous. I rather deal with hypoglycemia than hypo at any time. And hyperglycemia, because if the patient is consistently hypoglycemic, it means your treatment most likely isn't working, especially if your patient is still clinical, he's still PUPD, he's still polyphagic, then it means that most likely your treatment isn't working. Okay, so please bear in mind, especially the hypoglycemia part, the last thing we want is woman coming back from work, no one monitor the sugar level, looks at the coma, seizuring in the lobby, and by the time they bring it in for you, it's already too late. So you really have to emphasize that monitor diabetes in patient while on treatment is very important. So how about us? What do we we do for the client. So let's just say if I'm seeing a patient on follow-up, let's just say it was a diabetes patient, I said normally like if they are a control DM patient, I see them maybe once a month if they are in control. Okay. Um, always part of my history I'll ask them, how's the PUPD? Can you quantify the amount your cat was drinking? Can you compare it to maybe the past week, the past 2 weeks, past 3 weeks? Did the water intake increase? Did the pee increase? So let's say the clients may not be aware of the intake of water, but they should be jolly well aware of the intake of the output, which is the urine. So naturally, if you're drinking a lot, you're peeing a lot. So if they can't tell you, oh, I'm not sure how much he's drinking, then you ask, is he peeing? Or he goes, I'm not sure. Of course, you're sure. I mean, of course, you can check. You take him out for walks. Is he taking a longer time to expel his urine because of the higher volume? Is the color of the urine transparent because it's very diluted? You know, or if it's a cat, you can say, do you have to scoop out and change his litter more often? Do you see him going to the cat litter more often to go and pee? Polyphagia, very important because if your patient is not under control, the diabetes is not in check, the first thing that will normally pop up is the water intake is off, the pee quantity is significantly a lot, and these patients are normally still very hungry, they're still eating a lot most of the time. So you really have to always be part of the issue, ask them that. Now, blood glucose has to be monitored, and I love to ask my clients to bring me their blood glucometer machine. So in the corner here, you can see that there's this little device, let's say, the human machine. We use human and use the vet version of the client because the human ones are cheaper, the vet one is a little bit more expensive. We're fine with either one. But you really need to be monitoring blood glucose. I like to ask my clients to bring a booklet or jot down your blood glucose and let me see. I want to see over the last 2 or 3 weeks how's the sugar level like. You know, I may want to run fructose. It gives me an idea whether if glucose is under control or not. So that's very important. Now, one thing I want you to understand that if let's say you are in the clinic and you're going to run a routine blood for blood glucose in the clinic itself, you need to be consistent on the location of testing. If you're using capillary blood, means that you're breaking the ear, you're drawing blood, then you have to constantly use that because it's more consistent. If you're using venous blood, then you constantly use venous blood, especially if the patient's in the ward with you. Using plasma, then you also have to be continuously using plasma because there is some variation between interstitial blood as well as the venous blood which can get. Okay, so we have to be very careful about that. So please be consistent in your testing sites, especially if the patient is in the ward. Okay, you want to be watching that. Urine, well, not as reliable as learning. So why? Because you're not looking at hyperglycemia now. You're looking at hypoglycemia. And you need glucose to reach the renal threshold before you can find sugar in the urine. It's not a quantitative exam, it's a qualitative exam. So if you look at this strip which I have put over here, it's basically just a color change, whether it's darker, lighter, and whatever. And to me that's an issue because I'm looking at the color, and yeah, I know there's sugar. I know there is maybe a variation in color. But I'm asking myself, how much sugar is there in the blood? Is there a very high amount of sugar in the blood? Is this patient heading towards DKA, diabetic ketoacidosis, which is the fatal form of diabetes mellitus? There's all these question marks that I'm asking, and it really hampers and limits my ability as a clinician to try and treat this particular patient. And bear in mind, if let's say you were to check and you go, oh, the urine still looks normal, there's no sugar, so I'm happy. But it's still not measuring glycemia, you're still not looking at what's happening inside the blood. So to me, that's a real issue. So to me, I have clients, I don't have clients who been using the dipstick, the urine stick. Yes, I know, and the reason is that the dog is too aggressive. I totally understand. Or maybe the owner's cost constraint. And the urine dipstick is cheaper, so about 20 cents, 30 cents per string, versus getting a machine, versus paying for the needle support and the alcohol swabs, etc. So I know it's cheaper, you know. So sometimes we have this issue. And imagine if having a cat, and cat stand to pee on cat sand. It's going to be really challenging for you to try and use your instinct to try and determine whether there is high sugar level in the urine or not. Okay, so that comes another challenge which you have to really think about. So I tend to advocate always using okay, very, very important. Okay, now home monitoring again. So I tend to emphasize get a glucometer. Okay, can be a normal cheap one which you buy from the pharmacy for 120 ringgit. Teach clients how to take blood from the ear. I tend to get clients to do blood monitoring, especially the first few weeks that are starting on trip at least twice, at least at the time before they should, before meals, twice a day. Urine sticks, urine sugar sticks, not the best option, but like I said, I would use it if I really, really, really have to. The owner's cost constraint. If the dog is too aggressive, it's something I would consider. But you know, this glucometer would still be the superior option. Monitoring water intake. I love to ask customers to have a journal. You know, just make a mental note. Write a journal. Let that just keep track of how much water your dog or your cat is drinking. Measure it out. Okay. Is your cat suddenly eating more? Is he suddenly very hungry? Is he ready to bin? Is he begging for food? That could be another sign that sugar is out of control. Okay, so teach clients how to monitor clinical signs at home. And if they see anything funny, they should bring back into the clinic immediately. Now, all of us are trained in that school to do the blood glucose curve. Okay, and this measures how the sugar levels are like in the blood over a 24-hour period. So if you notice those red arrows that I put into the curve, those red arrows are examples of points of time when we actually draw blood and we actually mark. And the reason why you want to do this is because you want to see where is the nadir. The nadir is the lowest point where the sugar actually drops. So what happens is that usually it's given at 0 hours over here. And over 24 hours, we are drawing blood, we are drawing blood, we are drawing blood. Then we are trying to see how long does it take for the sugar to actually drop. We're trying to see is the sugar even dropping. Okay, because when we try to catch where is the nadir, where is the optimum time. Okay, so this is where it drops when it goes up. This is where we're going to shoot another one on the screen, see how it's going to behave. So this is actually very important. It gives us information about how long our jet or post is going to last. This is information about is it even working? Because there are cases where maybe the amount of insulin which you're giving just isn't enough, or maybe this patient is insulin resistant. So even if you jab and there's a potential and there's no nadir over 24 hours, it's just a straight line, like maybe even the line comes up. So this is something that you really have to consider. Okay, for me personally, I tend to modify my glucose curve a little bit more. The reason why because I'm not a very big fan of walking them every 1 to 2 hours and drawing blood because it really stresses them out. Then you may get a stress hyperglycemia because every time they see you, every time they see you, they're gonna ask you again, oh, you're gonna pop me again, oh, I hate you, you know, that kind of thing. And then that's just really going to make their stress level go up, and that's just really gonna maybe, you know, maybe give you false positive, a false representation of how the glucose curve actually looks like. So I tend to modify mine and maybe ask the client to do, or maybe not only even more, maybe we'll do it every 3 to 4 hours instead of every hour, every 2 hours. I generally don't encourage doing the glucose curve indoor because maybe in the ward the patient could be really stressed out. And if you're really stressed out, they may be having consistently high glucose anyway. And that's not going to help with giving you a proper blood glucose curve. So generally, we traditionally take blood from the ear, okay? And if you are going to be doing the blood glucose curve, bear in mind that at the end of the 24 hours, the cat is going to have a really bruised ear. You may encourage infection, or you may get a hematoma, which is a clot within the ear. So basically, these ears which the cats have is becomes a pincushion, and at the end of the 24 hours, the cat really hates me for it. It becomes extremely head shy, it becomes extremely, some cats become aggressive, gets PTSD, post-traumatic stress disorder, it's like they see people and they hiss, because they're just thinking, you're going to kind of hurt me again, you're going to pull my ear again, that kind of scenario. So something that I tend to advocate, something that we use often in our practice, is non-invasive blood glucose monitoring, or continuous blood glucose monitoring. So there is a device in the market, it's called Freestyle Libre. You can see that circle, this little thing here and here. Okay, you will see that it's a device, it's about slightly bigger than 50 cents, and we can actually leave it onto a cat, and it comes with this black device here. This black device comes with the box, so after we attach it with surgical glue and with skin tape onto the patient, within 1 hour after the machine has calibrated, we can actually just touch the sensor and the reading then pops up. So you don't worry needles, you don't worry the stress, owner is happy, because the sensor is going to read and do all the work for you. But we don't live in the perfect world, and this device is pretty expensive. Now, 285 ringgit is something you can buy on Shopee. And this device will last for 14 days. The machine is smart. You can't do more than 14 days because the machine is going to flash and tell you, okay, 14 days is up, I'm not going to read the sensor anymore. You are going to be forced to change the sensor. Like here, if you were to buy this retail from the pharmacy, it's about 380 to 400 ringgit each. Everything's cheaper on Shopee and Lazada today, 66. So I don't know if you're doing shopping or not. But it's still pretty expensive. So imagine every 14 days you need to actually pay for this. Okay, every 14 days. Okay, you have to actually buy a new device to go and attach. So 285 ringgit every 2 weeks. Now, diabetic ketoacidosis. I won't touch a lot on this. The reason why, because this itself is another 2-hour lecture. But this is a more dangerous form. This is a fatal form of diabetes mellitus. If let's say you cannot manage your DM, if you cannot manage the patient's DM very well, or the client is non-committal, or the client is not able to commit to treatment, of the patient is an uncooperative patient, you might get this condition, you might get DKA, and this is where, because of excessive fat metabolism, okay, what happens is that there's an excessive amount of ketonic acids floating in your body, and it becomes a byproduct of just fat breakdown, and this leads to diabetic ketoacidosis. The patient is in a severe state of acidosis. It becomes an uncontrolled diabetic patient. These patients will develop neurological signs, seizuring, ataxia, tiredness, dullness, they may even slip into a coma. They will also develop vomiting because their CRTZ, the chemoreceptor trigger zone, will be triggered. They'll be severely dehydrated because of the severe osmotic diuresis. So you can imagine this. Your urine now has glucose, and your urine now also has ketonic acids as well. The combination of these two will create an increased osmolarity within the urine and draw even more fluid out of that patient of yours. And the combination of acidosis and severe dehydration and neural damage subsequently leads the patient to death. So we talked about how um, the goals of management earlier. So there are some new trends in diabetes mellitus management. Number one is that newer drugs are being rolled off. Sodium glucose co-transporter 2 inhibitors, we'll talk about that later. It's these two down here, Bexacat and Sanvalgo. Told you for canine diabetes, this particular product is still new. A nice paper was published last year on ACIPM journal about its use in canine diabetes. Continuous glucose monitoring system. The freestyle Veterinary now kind of move away from using poking the ear and try to use a more non-invasive, stress-free method of monitoring sugar. And people like specialists have been publishing stuff saying that a more of this treatment is to keep glucose between 4 mol to 15 mol. We're no longer talking about just okay, we can maintain high sugar, okay, you can maintain 15 to 20 ml anymore. As long as the patient is eating, he is happy, he is not polyurine, not polydipsic, not polyphagic, is fine. Currently there is new ideas of how we should approach our patients. We should be trying hard to try and hit between 4 to 15 ml as more often so therapy. Okay, so before we go into treatment, let's take a quick break first and allow people to go for toilet break. Alright. Okay, doctor. Do you have any questions? So far, no, doctor. Okay, good. So we'll break for 5 minutes and we will continue after that. Okay, doctor. so we have break for 5 minutes. Shall we continue? Yes, can. All right. Okay. So this is the last section actually for diabetes mellitus. How do we treat for it? Um, okay, just a quick one. Did you know that hypoglycemia causes glucotoxicity to beta cells? So which means that if let's say you have a diabetes mellitus type 2 patient, um, which means that the patient has got some beta cells left. If you don't bring the sugar under control, and if the sugar is persistently high, the hyperglycemia is going to damage and kill off the remaining beta cells and turn that patient into a severely insulin dependent diabetes patient. Okay, so bear that in mind. Alright, first thing, this is for cats, oral hypoglycemic agents. So the most common one is a pretty old drug that we still use today. Is something called glipizide. It is a sulfonylurea class, and it is easily available. It's cheap and cheerful, and it is very widely used. There are some side effects, and the most important one is it causes vomiting, irritates the stomach, and sometimes in some cats they become anorexic on the product. How it works is that it stimulates the secretion of insulin from beta cells. So which means that whatever beta cells you have left, let's say maybe you have 20% left, it literally turbocharges them and makes that whatever leftover pancreatic beta cells have squeeze out whatever insulin you can get. The downside to the drug is that due to the chronic overstimulation of insulin secretion, it actually promotes beta cell exhaustion and kills off whatever beta cells you have left. So that's why a lot of these guys, after a while of being on glipizide, may eventually require insulin therapy anyway. The new class of drug, SGLT2, sodium glucose co-transporter 2 inhibitors, are licensed for cat patients only. There's two in the market currently. One's called bexagliflozin, or Bexacat is a trade name, and Venagliflozin is called Sanvelgo. Unfortunately, not here in Malaysia yet. Hopefully one day it comes. I've never had the chance to use it. And how it works is that it actually increases the glucose sugar. It makes the cat pee sugar even more. Now, its mechanism of action is pretty interesting. It lowers the cat's blood glucose by increasing the amount of glucose being peed out in the urine. It's a once a day dosing, and generally based on literature, it doesn't that the cat do not require insulin when they are on the SGLT2 drug. Zenvalgo is in liquid form, whereas Bexacat is in tablet form. So in this case, a lot of times, if this drug ever comes to Malaysia one day, it is something that I hope to use, because I do have clients that are really uncomfortable with needles, and they would rather give the cat oral liquid medication anytime versus having to jab the cat. And of course some cats just aren't that friendly, just aren't that cooperative, and you may not allow the client to actually jab and give the insulin. But if you can give them oral drug hide in the food, or you can think of a smart way to peel that particular cat, which could be easier for the client. But unfortunately, we don't have this here in Malaysia yet. Now, how it works is that it prevents the cat's kidneys from reabsorbing glucose into the blood. So it causes a significantly excessive glucose secretion via the urine. So then they keep peeing out more of this glucose, way it lowers the blood glucose concentration. How it works is that um, hexaglyphosine or glyphosine will block off the sodium glucose transporter through proteins. Okay, now these proteins are responsible for pulling in glucose in the molecules back into circulation, reabsorbing them. But this particular drug actually prevents the glucose from being reabsorbed. Hence, it forces glucose to leave the body via the urine. Now, is it the perfect drug? There are some risks involved, commonly diarrhea and vomiting. It does, or it may potentially cause pancreatitis to happen. Risk of ketoacidosis also could occur, and it is a paradox. In fact, these patients they develop something called euglycemic ketoacidosis, meaning that they don't have high blood sugar levels. Their blood sugar levels may be on the lower end of normal, and they develop ketoacidosis anyway. And why this happens actually is quite interesting because see, these patients don't have insulin or they lack insulin. So even though you have got glucose running around inside the body and it's normal because you're only peeing all of that glucose, so you don't have very high glucose levels. But because at the same time you don't have insulin as well, so you can't make use of that glucose within circulation. So when that happens, the body still breaks down fat, it still breaks down protein, and you still get ketoacidosis at the end of the day. You still get severe dehydration because you can imagine you're peeing out a lot of glucose now, combined with the ketones, combined with the maybe ketonic acid, so the patient is extremely dehydrated because of that. So then they develop the paradox is a euglycemic ketoacidosis because we're always talking about how if you control the diabetes mellitus, then these cats are going to get ketoacidosis. But in this case, you are controlling the diabetes mellitus, you're controlling the concentration of sugar within the body. But we fail to understand that maybe these cats don't have enough insulin to actually break down the sugar and use sugar as its predominant source of energy. And they still have to break down a whole lot of protein, a whole lot of fat, and they still get ketoacidosis anyway. Now remember we talked earlier about how because of glucosuria, a lot of these patients come in with UTI. So because now we are increasing the concentration of sugar within the urine, so the likelihood of a urinary infection also increases as well. Now, the most common self-limiting side effect of this particular drug is actually diarrhea. And about half of the cats in the literature who start on this treatment actually develop diarrhea. Some of them may resolve within 7 days and they're perfectly fine after that. But there are some patients that have persistent diarrhea forever and ever while they're on this medication. Now, there are two other drugs or two other classes that we will just touch briefly. And one is the alpha glucosidase inhibitors, and the other one is the incretin. So earlier we talked about the sodium glucosidase inhibitors, so this is the alpha. And the product it commonly used is actually acarbose. What it does is that it prevents carbohydrates from breaking down to sugar within the gut. It prevents the intestines from absorbing that sugar. So what happens is that the patient may makan, so postprandial means lepas makan after eating. So after eating, the body can't absorb the sugar. So because you can't absorb sugar after eating, your sugar levels don't spike, your sugar levels actually don't go up. Now, as a sole agent, acarbose is seldom used or ever efficient. It is normally used in combination with insulin as well as a proper diabetic diet. The other drug is glucagon-like, is incretin, it's a glucagon-like peptide 1 drug. It is a gastrointestinal hormone and is normally used alongside insulin. GLP-1 increases insulin secretion, again it acts like a sulfonylurea. It protects whatever beta cells you have left from toxic and oxidative injury. It delays gastric emptying time and increases satiety, so it helps to reverse the polyphagia issue, makes the patient, the cat, feel a little bit more full. But more research is needed. Now, most of these products are rarely used in plant medicine, okay, due to cost, not commonly available, and there's still lack of research in terms of its effect and whether or not it's really going to be useful. Okay, let's sidetrack a little bit. Okay, so let's talk a little bit about CGMS, continuous glucose monitoring system. Um, the modern goal or the modern idea about glucose management is to try and keep glucose levels between 4 to 15 mmol per liter. CGM is the new standard of care because for patient welfare, it's a whole lot better. And when you want to look at how the sugar is trending, it's a whole lot more easier as well. And it makes it easier for us to make decisions about whether we should increase doses, drop doses, or even change the type of insulin that we're going to be using. This method of testing does not interfere with regular pattern of insulin exercise, food consumption, leading to more reliable results. Now, what the statement means is that a lot of times, if you're going to be building or creating a glucose curve, maybe once a month or once every 2 months, um, most of the time these patients will be watered in overnight. And why this is the case is because the owners won't have time, or the owners won't be able to keep poking and checking and building that glucose curve. So a lot of times these patients have to be in the ward. So it's out of their comfort zone. They're under stress because the sugar levels to spike. It takes them away from their regular activity because maybe at home they're chilling with their other dog friends or their other cat friends and they're happy running about. But now it takes them away from all of that, and that could affect or interfere with how the school is going to behave. Just a side note is that when you're using this kind of machines, the freestyle libre, you're monitoring the monitoring interstitial glucose. So if you were to take a blood glucose sample, the readings will be different. It doesn't mean that you can't use it, doesn't mean that it doesn't work. It just means that there is a lag time between the diffusion of glucose from the bloodstream into the interstitial space. The benefits of the product far outweighs the cons, and I would strongly encourage you to consider using this for patient welfare and to improve clinical outcomes for your patient. Okay, so we've taken a break, so let us continue. Okay, let's talk about insulin next. So, a lot of what we are going to be looking at would be based on the 2018 American Animal Hospital Association Diabetes Management Guideline for dogs and cats. This is considered supposedly the Bible for insulin use for management of patients with diabetes. As far as I checked recently, there's been no new guideline yet, there's been no new update. I guess what they're thinking is that if it isn't broken, we're going to fix it. And we are still using this. But I will be talking about some new stuff that's come out in the market in terms of insulin usage and opinions about it. So, insulin is basically divided into three types based on the duration of action. So we've got short-acting insulin, which is this guy here. Okay, we've got intermediate-acting insulin, and we've got long-acting insulin. So for short-acting insulin, we've got regular crystalline, spot and lispro, which is commonly used in plant medicine. All right, we have intermediate-acting insulin, which is your Lantus and NPH. We have your long-acting insulin, which is your Etamil, Glargine, and PZI. Now you will notice later on in my slides that a lot of the stuff we have here are overlapping with human medicine. And the reason why is because it's a bit challenging to get fat license insulin here in Malaysia. But I'm using quite a fair bit of material from the AHA guidelines. This is something that is taught in our textbook, so we're going to be using this for now. And at the end, I'm going to be talking a little bit about something new that's in the market. So for short-acting insulin, I like this orange box here. This is Novo Rapid. This is my go-to short-acting insulin if I ever have to use it. And I use it a lot in my DKA emergencies. Now, why do we need a short-acting insulin? It brings down the glucose rapidly. can be given IV IM subcut. Because of its short-acting nature, they normally have a duration of action of only 2 to 6 hours. So after that, from my experience, normally about 2.5, 3 hours. And after that, sugar levels are spiking again. Bear in mind that if you're administering this short-acting insulin, route of administration is important. If you're giving the patient IV, they will expect the patient to respond quicker, faster. If you're giving it subcut, it may take a bit longer. If a patient is dehydrated, especially a lot of these guys coming in AKA, they're going to be severely dehydrated. So if they're severely dehydrated, then we expect the time of action to be short, to be longer. It takes longer for the drug to kick in. Now, you may ask, why is it I prefer Aspart versus Lispro and versus Homolina, which is your regular crystalline? So, based on literature, Lispro and regular crystalline can be used. In fact, if you are looking at American literature on Vet or these kind of websites, a lot of them actually prefer regular crystalline to Aspart, which is this yellow box here. I would prefer to use that if I could, but you have to understand that insulin in Malaysia, you won't get everything available all the time. Mobile rapid can be bought fairly easily from most pharmacies. If you walk into most of the big chains like Big Pharmacy, El Pro, or one of those guys, they will most likely stock Novel Rapid. You don't have time running around if you have a DKA patient to go hunting for regular crystalline. And I can tell you for a fact that here in Penang, where I practice, I've called multiple pharmacies in the past. They do not stock regular crystalline. I've called hospitals in the past, and they also do not stock that. So it's a bit challenging to get regular crystalline. So in times of emergency, we use whatever we have. And normal rapid, which is Aspart, tends to be something that I've used many times before. I've saved a number of DKA guys with it. And there is some literature looking about the use of Aspart in DKA cases. Alright, so this will be the thing that I normally use. But if you're lucky and where you practice, you get regular crystalline, so this will be sort of like the first or the go-to short-acting insulin that most nutrition actually talks about. Intermediate acting insulin. Okay, so we have got two NPH, neutral potash DON, and Lente. Let's talk about Lente first. Now, Lente is the sort of like the gold standard for canine insulin because in the West, in the UK, Europe, America, Insulin and Caninsulin, which is the brand name or trade name for Lente, is the vet licensed insulin. That means it can be used for our cats and dog patients. It's licensed for it. Means that the pharmacology board of the license is okay. You may use that safely in dogs and cats. Okay. It used to be used in human medicine a long time ago for Lente, but I've since withdrawn it, and the reason why because it is unfortunately a porcine-based insulin. So what they do is that they go to the slaughterhouse, they collect pancreas, and they actually suck the insulin out of the pancreas of the pigs. They extract it out of it. And they bottle it and they sell it as Lente. So it's not. So there's of course controversy with its use. I have used it a few times before. I have had customers of mine come in from overseas, and their patients were already and their pets were already on insulin, already on Caninsulin from years from a long time ago. When they came to Malaysia, unfortunately, Malaysia does not have Caninsulin and insulin legally because it's not licensed. So these patients may sometimes have to fly out of the country to bring back insulin and Caninsulin to be used for their cats and dogs because the cats and dogs are used to using that particular insulin already. I have used it before in some canine patients and some feline patients, and it works really well for my canine patients. If you are a patient that is just newly diagnosed with diabetes, it's actually a pretty good insulin to use. It's given some kind works 8 to 12 hours, also twice a day dosing. It's just unfortunate that we can't use it here significantly because number one, it's really expensive. Gasoline may cost you about 300 ringgit per bottle. And if you're using it for a small cat, it will last you about 3 to 4 weeks around there. And that doesn't take the cost of the alcohol swabs, the needles, and the difficulty in using because if I'm not mistaken, cutting still comes in a pen, but the vaccine still comes so you have to draw out into a syringe and then inject into the cat. So in Malaysia here, I used to use a lot of NPH long time ago. It's called Homelin and as a brand name. It was my go-to drug. Initially, whenever I had a dog come in with diabetes mellitus, not really well can be more under control. But the last 6 to 7 years, I haven't used Homelin N anymore. And the reason why I haven't used Homelin N anymore is because they have discontinued Homelin N here in Malaysia. And the reason why, because there's actually a generic called Insugen N, okay, or NPH insulin. It's a local Malaysian-made generic. So because the Eli Lilly, which was the manufacturer and distributor, Holland has discontinued this product, and now the human medicine in Malaysia they're using Insugen N. Insugen N is not easy to get. It can be found in some pharmacies locally, but it's not the easiest insulin to actually get. I don't know that in GH, Malaysian GH, they are distributing this Insugen N. So it is a potential it is a potential insulin that you can actually use for your patients. Okay, it is an NPH. It's just a generic NPH made by a local factory here. Now, long-acting insulin, as the name suggests, it is long-acting, and there are basically three that is commonly used in Batman, or three that is licensed or the research being published commonly shown. First one is glargine. In Malaysia, we have got the granddaddy, or the most famous one is Lantus branding. It's a recombinant DNA human origin insulin, which means that they actually take a human DNA that is meant to code for the production of insulin, and they slip it into a yeast or some other organism, and they sort of like create a GMO, genetically modified organism, and this GMO will then start creating and producing insulin. They then extract this insulin and they then bottle it and they sell it. Now it's more common used in cats. It is a potential option for dogs, but I've noticed that my dog patients don't do very well on Lantus. I can't really seem to get the sugar under control. So I use it a lot for my feline patients. Even my own cat, Ingrid, he's a diabetic patient and he's on Lantus as well. He's on twice a day dosing subcutaneous. And in some cases, why we do encourage owners to monitor these patients on Lantus at least once or twice a day at home is because the effects may last up to 24 hours. Now, the drug that I often use for my canine patients now, the insulin is actually insulin ablatomir. You'll find it in Malaysia under the brand name called Levemir. Again, it is just like glargine. It's also a recombinant DNA human origin insulin, but its molecular makeup is a little bit different. It's often used in dogs when NPH and lactate is not working. I use it as my first line currently because I don't really have easy access to lactate and to NPH at the moment. It works really well. I get good control over 6, 7, 12 hours, and my patients are using it twice a day. It is not commonly used in cats because supposedly the duration of effect is too long. I think I've used it in 3 cats over the last 4 to 5 years. We didn't get a very good effect. We suspect one of the cats that got somogi after that. So it's not something that I would encourage using. This is something that supposedly is the best for cats. It is a US FDA approved insulin for cats. Prozing is the brand name. PZ9, what I mean zinc insulin. Again, it's also a recombinant human DNA insulin. It's a long-acting insulin, and it may last up to 24 hours in some cats. I've never actually used this before, but based on the literature, based on the data that's been produced with the use of this particular insulin, it's actually pretty good, and it is currently being advocated as the best insulin for cats. Now, we talked about something new. So, Tocho is the new one. So, remember earlier we talked about how um, I don't really use glargine on my dog patient because I can't seem to get very good control. So, a paper was published in 2024 in ACVIM, the Internal Medicine Journal, and they talked about using Tocho Sonostar. It's still the same company as the other glargine, the latter Sonostar. But what they've done is that instead of 100 unit per mil product, they've actually created something that is 300 units per mil. According to the paper, they claim that it has a very wide dose range, so it's very safe. And surprisingly for this particular product, it's safer to use on dogs compared to the other one. Um, it has got lower potency, so you get less spikes, you get less swing of the sugar of the glucose. It has a pretty long duration of action, and you may only need it once a day dosing. The mean initial dose from the paper was 0.5 units per kg once every 24 hours. And the mean dose was eventually 0.0 units per kg every 24 hours. I've never used this before because I'm relatively comfortable with whatever protocols that I have. Um, so far, this is the main paper that was published for this particular insulin at the moment. And so people have been talking about it. There's some buzz in the endocrine community where they say maybe potentially this is something that we could actually use for our canine patients down the road. Okay, so bear in mind that insulin is not a wonder drug. It does have certain issues which you have to be aware of. Skin allergies, not too common. I've never seen that before. Maybe one cat develop some skin issues, but under control. But the more important one is hypoglycemia. And what happens is that if the client isn't monitoring the patient, if they're just jamming, and not watching where the sugar is hitting, what could happen is that they may inadvertently push the guy into or the girl into hypoglycemia, causing severe neuroscience such as seizures, shivering, twitching, incoordination, ataxia, and subsequently death. We had one case where the client could not check and they just kept jabbing. They didn't check the dog for the whole week. And from what I understood, and they brought the dog as an emergency one afternoon. He was recovering, seizuring, was hyperventilating. That dog nearly died. We had to give him sugar infusion, glucose infusion for like 2 days, trying to get the sugar levels up. And that was because the owner wasn't monitoring the sugar level. They didn't do a proper glucose curve. And what happened was that the patient unfortunately had developed hypoglycemia. Patient survived. The effect was that the patient had turned blind after he recovered from the hypoglycemia episode. So the rule of thumb for all my clients is please always give insulin before or after a meal. I will not give insulin on an empty stomach. Okay, so how do we choose which insulin to use? Always understand what is the state of your patient. Is he a stable diabetic patient? Is he a patient where okay I can use something long acting, something medium acting? Or is he a DKA patient where I need to use short insulin like this pro novorapid to try and bring the sugar levels down quickly? What species is it? Because I mentioned earlier, some insulins work better for certain for other species, so please bear that in mind. And what's available on a regular basis, because I mean there's no point you want to tell like, yeah, we should be using that. Yeah, we should be using P7. I can buy it for you, but some there's no stock in the country. Stock. how to actually use a different product and rebuild the whole protocol again. So bear in mind that PCI and Lente is very still as of now. And it will take some time, maybe they will never come to those. But hopefully comes one day. And then bear in mind that NPH from Eli Lilly has also been discontinued within Asia. So if you're going to be thinking about something long term, you have to be thinking, what can my clients afford? What can my clients do? If it's easy, can they walk into a store to buy the just down the road? Or do you have to fly to the neighboring country to buy their insulin and cost more? Make life easy for clients because diabetes mellitus is going to be a standing disease, going to be something long term. If life isn't going to be made easier for the client or single, then they may not be that compliant. They may not want to continue treatment, and they may just say, I give up. And then you would have a failed diabetes mellitus case. So always bear in mind, is the patient responding to insulin? Always monitor the patient and always understand that if it's not doing better, maybe it's the insulin that is not really working. Okay, so please bear that in mind. Now, many cases of DM can be complicated to manage due to various factors. It is not part of this lecture because there are another 2 hours. A more comprehensive lecture on complicated diabetes and DKH should be planned. Alright, that's it for tonight. Okay, that's it. So, does anyone have any questions?
I have two questions. First, SGLT2 drug. Is there any effect on renal and on renal because the drug cause increased glucosuria, right? So, is there any effect on the renal of the patient after use it for a long time?
Okay, that's actually a good question, and it's something that I've asked myself. But according to the literature that's been published so far, it's a very new drug. It was only launched in, now it's 2025, only launched in 2002 or 2023. So last 3 to 4 years. Supposedly, manufacturer says it's very safe. Okay, so supposedly. But if you're asking me, I don't think there's enough data yet to actually show that there is actually going to be kidney problem. Because what the manufacturer, what they're going to argue is that diabetes mellitus itself may lead to kidney failure. So you can't really argue saying that increasing glucose is going to be hasten that. I guess you could argue that, but it's a bit difficult right now because we don't have enough data for that. It's like how when people talk about the use of Apoquil blocks off your JAKS pathway, a lot of vets, including myself, need to be actually concerned because you block the JAKS pathway, you're going to predispose that dog or Apoquil to actually cancer. That kind of scenario. But the manufacturer says that you can't prove it because all dogs have got a similar chance of getting cancer. I guess is there enough data to actually prove that if you put a dog on Apoquil, it's going to get cancer? But do I see dogs on Apoquil getting cancer? Yes, I do. So maybe anecdotally, when the drug comes into Malaysia one day, we may start seeing this. But you have to understand that most of the drugs, Sandalgo as well as Bexacat, is manufactured by Boehringer Ingelheim as well as Elanco. They're considered giants within the industry. So if anybody's going to come out with data to claim that more usage of Bexacat is going to cause faster or more progressive renal failures and glucosuria, it will be really challenging because if you're going to come up with the kind of research who's going to fund it, you have to come up with proper data. If not, those big companies, big pharma is going to do something and try to shut it down. Because when Apoquil first came out, there was a lot of chatter about Apoquil potentially causing increased chances of cancer. And what the scientists did was that they came out of their own paper to refute that and to say that that's not the case. So your question is a good question. It shows that you're thinking. That's actually really good. I had the same thought as well. But because it's not licensed in Malaysia, so I don't get to use it legally and in not enough scale. So I can't really give you an answer from my own personal experience. But I'm putting it in my lecture because it's new, it's something that you should be aware of. Because for all you know, maybe 2 years from now, if you get a CAT expert coming for your external exam, he may ask you about it, you can like, go right and impress him. Yeah, I don't have information, but I know about it. And maybe he'll be impressed. But I don't have enough experience to actually know that, yeah, these cats of mine, they go into kidney failure faster. Because argument can be that you're already diabetic, so you're already predisposed to renal failure anyway.
Okay, doctor. Okay, for my second question, earlier you talked about how cat can go into remission of diabetes mellitus after they losing weight. So if they gain weight again, can they have back the diabetes mellitus again?
Yeah, most likely because you understand that the term we use is wax and wane. That means it comes and goes, comes and goes, comes and goes. So it's not just weight alone. Even other diseases as well, like cats with chronic pancreatitis as well. Um, some cats and some cats may develop a condition called acute or chronic pancreatitis, which means that they initially develop an acute phase of pancreatitis, and they turn into a chronic phase of pancreatitis. And then after a while, something triggers a pancreatitis against stress or something. And then the pancreatitis then gets flat again, and the diabetes then comes back again after that. So it's not just the weight possible. Weight is one thing. Um, Acute or chronic pancreatitis can be another thing as well. Other things as well, such as certain stress, because when cats are stressed, you will learn, I think, the lecture, I think. When you're under stress, the cortisol gets pumped up, then cortisol then acts to make the cat more insulin resistant. Because you gave up on the correct insulin. And then now what happening when you're under stress, cortisol then causes insulin resistance. Then obviously your diabetes then comes back again after that. So those are a lot of various factors, not just so weight's one of them, but stress factors, disease factors, infection, because certain infections, like some cats with chronic FIC, but FIC itself may be a trigger for the diabetes mellitus at the same time because of inflammation of the bladder, and certain inflammatory mediators may work to cause insulin resistance by attaching themselves onto the insulin receptors as well as the glucose channels. So that, yes, weight is one thing, but other things as well can also be an issue.
Oh, okay, alright, thank you, doctor.
Okay, right. So are there any more questions? Okay, so if there are no more questions, shall we end it for the evening? Okay then. So next time I see you guys will be next Friday night, I think. So I'll be in touch with your class rep. Thank you and bye.